Welcome. I'm John Iannian at the University of Michigan, where I serve as director of the Institute for Healthcare Policy and Innovation and a senior advisor to the Center for Global Health Equity. And it's my pleasure to welcome you to our panel on data science for health in Africa, one of the featured panels, part of the Africa Week, sponsored by the University of Michigan in collaboration with partners across Africa. It's great to have you join us today, capping off a week of fascinating discussions of different issues related to policy and development in Africa and collaborations underway with colleagues at the University of Michigan. I'd like to welcome and call on my co-moderator, Professor Masi Mutumba, to introduce herself.
Thank you, John. Just a minute. Okay. So my name is Masi Mutumba. I'm an assistant professor in the Department of Health Behavior and Biological Sciences at the School of Nursing. And it's a pleasure to be here with you all. I'm looking forward to the discussion on data science and how it can be applied within the African context. But before we get started, I would like to highlight an initiative that we have that is really in line with the panel discussion today. So the School of Nursing has a really deep interest in data science and applying data science or big data analytics to chronic diseases. And I think this is really relevant to the context of Africa, especially when we think about chronic diseases. So here at the School of Nursing, we do a lot of our center. We have quite a number of centers that are focused on various themes, statistical methods, but this center stands out in its focus on novel statistical techniques that could be used to harmonize data from different sources to create this sort of complex data sets that can allow us to examine health and well-being at very different levels. So we could look at country level artifacts, we can look even much further at subnational or even regional levels. And this is very novel in the study of chronic diseases, but also that we want to be able to use data analytics to inform policy. And that really requires that we should be able to present this data in ways that are easy and meaningful to the communities of interest. And here, in that regard, this center does a very good job on visualization of high-dimensional data to really be able to inform policy and also facilitates aspects of curriculum development. So for those who may be interested, the center is run by two directors, our Associate Dean for Research, Dr. Deb Barton and Dr. Ivo. So without much further ado, I'll turn this back to John for our first speaker.
Thank you, Masi. And so now I'd like to briefly introduce our panel for today's session. This session is co-hosted by the Center for Global Health Equity, one of the newest university-wide centers which launched last year. It's designed to promote collaboration across our campus and around the world to improve global health, particularly by collaborating with colleagues in low and middle income countries to develop greater impact of the work that we do in collaboration. And this is the website for the new Center for Global Health Equity. Those of you who are interested in learning more about what's happening at the University of Michigan and with our partners around the world can find useful information here on the website. So the center has four primary themes that have developed over the past year. First, focusing on strengthening systems for health. Second, evaluating the social and environmental determinants of health. Third, empowering women and communities to improve health. And fourth, the topic of our discussion for this morning's panel on data science. And data science is really a cross-cutting theme that addresses each of these other three themes, as you'll hear examples of from our speakers on the panel today. So as facilitators for today's discussion, Professor Mutumba and I will be introducing and interacting with our four panelists, speaking in the order shown here, beginning with Professor Akbar Walji, from the University of Michigan Medical School, followed by Professor Amina Abubakar at Aga Khan University in East Africa and the Institute for Human Development there. Our third speaker will be Professor Girma Aweki at Addis Ababa University and the College of Health Sciences in Ethiopia. And our fourth speaker will be Professor Pam Jagger from the University of Michigan School for Environment and Sustainability. So Dr. Walji, who will speak first, is an associate professor in the Division of Gastroenterology at Michigan Medicine. He's also director of the Michigan Integrated Center for Health Analytics and Medical Prediction, also known as MyChamp, and associate director of the Data and Methods Hub at the Institute for Healthcare Policy and Innovation, also at the University of Michigan. He serves as visiting professor in the Department of Population Health Sciences at Aga Khan University in East Africa. And his research focuses on the use of machine learning techniques to implement decision support tools and systems to facilitate more personalized care for delivering efficient, effective, and equitable therapies for chronic disease in low resource settings. Welcome, Dr. Walji.
Thank you, John, for the kind introduction. I'm truly have a great pleasure of being here today. I'm humbled for this opportunity and looking forward to talking to you a little bit more about data science in Africa. So I think it's important to start off with, what is data science? And we're all succumbed to this deluge of data, this waves of various amounts of vast amounts of data, whether it's in mobile, in cell phones, in banking, or just in health. And the question is, like Dr. Mutumba said, how do you take this complex data and make it simplified in a way using analytics, processes, systems, what we call data science, to extract knowledge, truth, to habit, right? We want to be able to get this complex data in a simple form so those policymakers, those physicians, those community leaders can make better calls on what they need to do for their population. Take for example, if you found a hot zone of dysentery in Kibera in Kenya, how do you advise policymakers to improve clean water and sanitation in that community? Another example that we're going through right now is during the COVID-19 pandemic. We've not seen more logarithmic charts than ever before, whether it's to understand infections rates in our community, the importance of personal protective equipment, whether it's for understanding the need for mechanical ventilations, or even to understand what's the vaccination rates in your community. Data is around us, and we're seeing more data that needs to be used to help make things. And what's evident by this is our National Institute of Health director, Francis Collin, has said that data science drives scientific discovery, and that data sets are truly going to be the currency of the future. And to prove this, the NIH and Fogarty last year had a grant opportunity specifically around how do we harness data science for health discovery and innovation in Africa. And they had 4 key pillars. The first initiative was around developing research hubs. These hubs that can excel in the performance of data and data science to answer pertinent research questions in your community. Under this initiative, they were going to fund 5 projects, each worth $6.5 million each. Initiative 2 was very insightful, saying that, well, yeah, maybe you have the data, maybe you have the infrastructure, but you actually have the African data scientists that can actually help analyze this data. And so they emphasized an initiative around data science training programs in Africa. Under this mechanism of funding, it was $1.75 million for the total of those 5 years, and they were going to fund 4 of these initiatives. Initiative 3, also extremely important, the ethical, legal, and social implications of data research. A key priority as we start to use more and more data and more personalized data. Under this mechanism, they too were also going to fund grants for $2 million over the 5 years. And then finally, an initiative around open data science, an open data science platform and coordinating center. This was one entity worth $11.5 million over those 5 years to help coordinate initiatives 1 through 3, with the ultimate goal that if they could actually use this data in a more shareable manner to help the entire continent be their priority, to help facilitate that open data science and to provide that coordinating center for the 3 initiatives. The University of Michigan had the opportunity to apply for Initiative 1 and Initiative 2, which were extremely this was due at the end of December, and we hope to hear roughly around August of 2021. The collaborative Initiative 1, which is this research hub, involved partners from the Aga Khan University, the Kenyan Medical Research Institute and Wellcome Trust, the Clinton Health Access Initiative, and the University of Michigan. And the title of this grant was Utilizing Health Information for Meaningful Impact in East Africa Through Data Science, Uzima DS, Uzima Swahili for Health. This was submitted by Dr. Amina Abubakar Ali, that from later during this panel, and ourselves at the University of Michigan. The second initiative that we applied for was with our partners at Addis Ababa University. The title of this was Translating Information to Knowledge in Ethiopian Data Science, TRAINed, a new training program at Addis Ababa University for translating health data into science. Extremely important initiative around training of African data scientists. This was submitted by Dr. Girma Aweke, again, a panelist on this call today that you will be hearing from, as well as colleagues, Dr. Phil Boonstra at the School of Public Health and Dr. Cheryl Moyer from the University of Michigan and the Department of Learning Health Sciences. Just with the preview that so far, there's such great opportunities for future collaborations, some of which I was hoping to just discuss, but maybe the impetus for further discussion during this call. So privacy and security, an extremely important area as we think about using data across countries and across regions, knowing that one of the potential limitations is that regulations in each country, whether data can be shared in the cloud, whether the personal health information can be shared more accessibly, and the potential opportunities in data science around synthetic data, around federated models, where each data set can remain in the country, but you can share algorithms together to better the health of the community. Climate, environment, and health, a great opportunity of augmenting this data with the available data. You will hear later on from Dr. Pamela about potential opportunities in this space, whether it's to see whether climate influences migration patterns and health, or to, through catastrophic events such as floods or earthquakes, how does that impact someone's health? The other potential low-hanging fruit is, again, leveraging demographic surveillance sites locally in each country. These are data sets that potentially have had ongoing recruitment over years. And the question now becomes, how do we take that complex information, simplify it, just like Dr. Mutumba said, so that we can give it to our policymakers, to the community at large, to have an influence in terms of their health. And then another great opportunity that's an initiative through the Center of Global Health here and Equity here at the University of Michigan around empowering women and their communities. In summary, in these limited resource settings, data science approaches are now becoming more accessible. They are this low-hanging fruit. Data is prevalent. We have African data sciences that are paving the path forward, but we need more. There's a center of excellence around African data sciences in Rwanda, but we need more of those. Technology is becoming less costly, right? Computers are much, much cheaper. And with the younger population in Africa having access to computers, this is potentially an opportunity for us to have data scientists across the globe in low and middle income countries that can harness the local data for public good and public health. this is not without barriers, clearly, right? So there are future needs. You know, we do talk about complex data that are sometimes not clean. A lot of energy and emphasis needs to go into cleaning that data. You know, novel algorithms, whether machine learning or artificial intelligence, can potentially help us do a better job of understanding this data. Resources are clearly needed for education in data science. Again, priority areas like the NIH and Fogarty have emphasized this to train our African scientists. And the infrastructure is still expensive. Taking data and aggregating it to then actually analyzing it, to simplify it, to then actually having impact, where we're actually translating this knowledge through interventions or through public policy, is clearly a pipeline that's expensive and needs to be facilitated. But I truly think that there's such a great opportunity, and I'm really excited about sharing some of the great things that we're doing as part of the University of Michigan, as well as our other colleagues and other institutions across the globe.
Thank you very much. It's now my pleasure to introduce Dr. Amina Abubakar, a leading scientist on child health and well-being in East Africa. Dr. Abubakar is a professor at the Medical College in East Africa at Aga Khan University, and also the director of the Institute for Human Development, also located at Aga Khan University. She is a senior scientist at the Kenya Medical Research Institute, Wellcome Trust Research Partnership in Nairobi. Her research focuses on quantifying the neurocognitive burden of early childhood diseases and developing culturally appropriate psychological measures for use in Africa. She's also very much interested in conducting research on culturally appropriate intervention strategies for at-risk children in sub-Saharan Africa. Dr. Abubakar, please.
Hi, everyone. It's really a pleasure to be here to talk to you about some of the work we are developing with colleagues from University of Michigan and other collaborators. As Akbar has introduced, we set out a proposal that we've submitted to NIH known as Utilizing Health Information for Meaningful Impact in East Africa Through Data Science. The acronym is SUZIMA. And really the motivation for this proposal is the acknowledgement that demographically, Africa is a very young continent, with around 60% of its population being less than 25 years of age. Early years experiences, whether it's biological, environmental, or psychosocial events, can have long-term impact on the health and well-being of people here. We have a lot of data that is being generated. However, we are not able to leverage on it adequately due to maybe lack of, unifying platforms. So we feel that data science properly implemented can actually help us make the most of this data and be able to inform policy. So our program aims at the objectives of our project. Sorry, I think I've moved too quickly. Oops. How do I go back, Mercy? Sorry about that. I moved a bit too quickly, so I'll just have to start the screen sharing. Sincere apologies. Oops. So objectives of the proposal is to create a scalable and sustainable platform to apply novel approaches that assimilate artificial intelligence and machine learning-based measures to serve as early warnings, and really to be able to address critical issues in two domains: maternal, newborn, and child health, and also mental health. So we see three very important gaps to fill. The first one is, how do we harmonize multimodal data? The second one is, how do we leverage on temporal data to identify trajectories that can help predict outcomes using artificial intelligence and machine learning-based models? But more importantly, how do we engage key stakeholders to really be able to identify pathways where we can disseminate this information and ensure the models really impact policy and practice at community and national level? So the platform, the Research Hub we have proposed to NIH has two important projects. One is a project on maternal, newborn, and child health. And this project will leverage on existing data sets and cohorts to try and answer several questions and come up with predictive models. I can give an example of one of the sub-projects. We intend to follow a cohort of almost 9,000 children whom we have early childhood data, extensive data, clinical, neuropsychological, mental health, prenatal, postnatal data. And at this moment, they're either adolescents or young adults. And since they're embedded within a demographic health surveillance system, we'll leverage on the demographic health surveillance data, which has been following them up every 3 months for the past few years, and also leverage on some information that we can collect through a geographic information system like distance from health systems, distance to school, access to some of these community services, to really be able to look at individual, household, and community level factors that predict long-term outcome. We also intend to have a project on mental health in adolescents and young adults. We are really interested in coming up with predictive models on suicide and depression among young adults in Africa. Now, within that project, we will have a component that is a data management component that will really try to harmonize the different data sets and try to come up with an accessible platform. We'll also have a very strong dissemination core. The dissemination core will work with partners such as CHAI, the Clinton Health Initiative, to really try and get these predictive models into the community. Yeah? One of our key targets would be to find a way to work very closely with government so that this can be applied. We have a very large partnership within academics. I'll talk about our academic partners, but also non-academic partners, the Ministry of Health in Kenya, the Clinton Health Initiative, Aga Khan Foundation, and also the William Davidson Institute at Michigan. All this to be able to translate the research into practice. Our collaborating academic institution is University of Michigan, Kembri Wellcome Trust, which is a research institute in Kenya, more than 30 years of research that has a really strong DSS system, and Aga Khan University. I'll talk a little bit about Aga Khan University, where we are based. And really at this point, I'll try to look at beyond this Uzima project. What are the opportunities for collaboration? So Aga Khan University actually is based in 6 countries, in Kenya, Uganda, Tanzania, Pakistan, UK, and we have opportunities to work across all these regions to do some work. I'm only going to highlight the opportunities within East Africa and Kenya, and because of time pressures, I'll only highlight 3 opportunities that I think are very key. So Aga Khan University is actually embedded within a university hospital within Kenya. And the university hospital has set standards for providing state-of-the-art facilities, but also with quite a lot of initiatives that provide opportunities for research. For instance, we are implementing electronic medical health system. And because we are a part of the larger Aga Khan network, this will reach almost, I think, estimated 10,000 people every year. That will be a very large data set. We have a lot of neuroimaging data that can be used for research. We have a state-of-the-art cancer center being set up. Our pathology department, we are developing a biobank. All this provides opportunity really to think creatively about how we can use this data. We have a surveillance system, a demographic health surveillance system, the Kaloleni Rabai's health surveillance system, which reaches 90,000 households every 6 months. And it's embedded within the health system. So community health workers who are volunteers collect data every 6 months about what different aspects, from clinical to food security and to many other aspects. And there's always opportunity to get more data from these systems. Lastly, Aga Khan is very keen on working within cohorts and developing a lot of cohort study. For instance, one of the major cohort studies, which we intend to include in the UZIMA project, is the PRECISE network. The PRECISE network, as you can see from this map, works across many settings within Africa and outside Africa. And what it intends to do is to look at pregnancy disorders. So we are not only collecting, they're collecting, blood samples, urine samples, phenotypic data, keeping track of aspects such as, maternal health, neonatal health, and all this data being collected provides a very rich data set that can be interrogated in many ways. Yeah? So in conclusion, Aga Khan is a small growing university in East Africa that is investing a lot into research. And we look at UZIMA, the project we have developed with Akbar, as one of the very first steps for potential collaboration. Thank you very much.
Thank you, Dr. Abubakar. And I'd like to introduce our next speaker, Dr. Girma Aweki, Associate Professor of Biostatistics at Addis Ababa University in Ethiopia, where he is also the head of the Department of Preventive Medicine. His research focuses on identifying, characterizing, and modeling vulnerability among urban populations, strengthening the use of health management systems for better decision-making, and developing statistical methods that improve monitoring and evaluation systems for health and related studies. Welcome, Dr. Aweki.
Slides, please. Thank you very much. I am going to present the African Data Science Training Program in East Africa. Next slide, please. I'm going to talk on 4 issues. The first is to show the status of data science program in Ethiopia and East Africa. Collaborations we are intending to have between Michigan University and Addis Ababa University. Opportunities to develop data science program, and also some ideas and data sets for future collaborations. Next slide. Why has data science training program in Eastern Africa? Well, in Eastern Africa, there are universities, old universities, which are well developed, like Addis Ababa University is one of the oldest universities in Africa with several programs. But for example, in terms of the data set we currently have in Ethiopia and Eastern Africa, ranges from DSS sites. One of the DSS sites, Amina has been describing in Kenya, the same DSS sites we have in Ethiopia, which is called Butajira, almost 35 years old. And the data used to be collected every 3 months, but now every 6 months, and census is taken every 3 years, up to 5 years. And there is a huge data set being accumulated. There are also routine data collected from different health facilities. We have different health service tiers in Eastern Africa. And a huge data set is actually accumulated. Some of them, aggregated using DHIS2, which probably in the future, this might have to be changed into individual levels. There are also data on diagnosis, medications, procedures, which should be well managed, mined, cleaned, analyzed. and report it for a better planning and decision making. Next. One of the issues, frankly speaking, is relating individual level data of patient social demographic variables to other medical and health related variables, so that relationship can be seen, patterns can be studied. And this requires mining large data sets, which is already floating in different institutions. There are other data sets in research, studies, student thesis. Recently, we started to document data from student thesis, and this is going to be a huge data in a very, very few years. So data mining becomes really very, very important. So that is now an issue with all this data set. And next, the question is, do we really have a data scientist or an expert that can deal with this kind of data? Next slide. Next slide, again. Next. Yeah, then, all those lists that I have skipped slides, they're all data sets in different institutions. So I'm going to talk about then why collaboration is required, why with Michigan University. As I initially was starting to talk about the programs that Addis Ababa University and other universities in Eastern Africa, there are several programs. Epidemiology and biostatistics, statistics programs, and health information systems programs, and computer science programs. All these programs are running in either health settings or in the College of Physical Sciences in Ethiopia and the rest of Eastern African countries. But the problem is, if you just take epidemiology and biostatistics program in Addis Ababa University, the graduates basically concerned with surveillance monitoring. And some of them are researching in universities or public health institutes. They can design, analyze, and report standard studies, but they cannot really mine large data sets because the training has not prepared them to do that kind of job. Statistics, they don't have good an understanding of health data. Although they basically learn programming languages and know how to write codes, they are not practically oriented. And a very little experience with also mining, dealing with large data sets. Next. And the same is computer science or information systems. Or these guys, they may not have good understanding of health data, don't have good understanding of statistical methods. Although they have some code writing, but sometimes not understanding the health sector may find ourselves not being able to link them very well. So this group, although they have a strong capacity in programming, code writing, understanding IT system, but fail to understand the other component of the data science. Next, please. Yeah, the same with graduate in information systems. So in general, what you see looking at all these programs do not really reflect a full situation for a data science master's program, or these programs do not really produce graduates which are good in the data science that we're calling. Except there, we cannot deny there's nothing on the ground. There are few, like there are courses being offered in the physical sciences at Addis Ababa University, physical science programs. And there are some initiation also on data science in this area, but not matured, not capable of supporting all other programs, and there is nothing in health. So that is really very important now to have collaboration with institutions stronger than institutions in Eastern Africa. Next slide, please. Then why University of Michigan? Because this university have a lot of qualities. In very good data science program and other programs also, strong other programs. If you go to biostatistics and public health programs, they are very good, strong programs, capable staff. And, I had an opportunity to work with them during this call, and I really find even the deans and department heads so cooperative, and we are very, very excited, very happy to have this working atmosphere with them. Next. Then, are there any opportunities to strengthen this collaboration? Yes. One of the things is because we have a huge data set, different sizes, different structure at different places. And this is a challenge, an opportunity also to bring them together, analyze, and make sense out of them. And these days, several funding organizations are actually supporting health information system. Ethiopia, 2 years or 3 years ago, have developed what is known as a National Information Revolution Roadmap. This is which interweave the district's health system with the region and with the national, so that information systems, data are high quality, and they are also used appropriately for monitoring and decision making. And there are also probably very few or almost none professionals in data sciences in this region. So this would be a good opportunity for us to materialize this collaboration. Next slide, please. Okay, what do the future have for us? And in the present collaboration, we are just starting to work on data sets that are already available, but there are other issues like climate change. A small research study has been done on this, which relates effect of climate change on some diseases. So if you take this a bit further, like malaria, diarrhea, which are very dominant disease in Eastern Africa, and surely climate have a lot of pressure on these diseases. And there are data, weather data for several years, disease data for several years, environmental variables also. So if you combine all this in the future and look at what will happen, and we'll have an opportunity to project what will happen in the future, how these diseases progress with changing climate from time to time. And currently, in health systems, the way data is being registered or managed is difficult, because everybody has to sit on certain computer, probably has to convert from paper into electronics or to a computer. But this trend has to change. So there must be a way that everybody can work even from their mobile, enter data even from their mobile while they are on duty, so that the data goes to the server, and then that can be accessed from the server and analyzed in different ways. Next, please. There is also a huge gap in Eastern Africa between provider and patient. There's no communication at all. If you go to tertiary hospitals, big hospitals in Eastern Africa, like one we have at Tekurambassa, the tertiary hospital, the specialized hospital, you see a lot of people lined up or crowding in card rooms and around. So there must be a way in which we can change this scenario, in which we improve communication between provider and patient on one hand. On the other hand, communication between departments within institutions, health providers. So there are tools now, artificial intelligence, programming, all this in data science can actually be very useful to solve these issues. And I think and hope that the future will provide a good opportunity for this type of issues. Next slide, please. Yeah, basically the use of IT, particularly writing codes to manage data, to mine data, to analyze large data, is very minimal in East Africa. Therefore, in the future, I hope that we will have opportunities to improve on this. Next slide. Thank you very much for listening.
Thank you so much. Now I'd like to use this opportunity to introduce Dr. Pamela Jaeger. She's an associate professor in the School of Environment and Sustainability here at the University of Michigan, and quite a remarkable global leader in the interdisciplinary population and environmental research. Dr. Jaeger's research focuses on the dynamics of poverty and environmental interactions in low-income countries, and she leads the Interdisciplinary Forest Use, Energy, and Livelihood Lab here at the University of Michigan, and is also the director of the National Science Founded Program on Poverty Energy in Sub-Saharan Africa. I'm Dr. Jaeger.
Thank you very much. What is happening here? Just give me 1 second from the beginning. Thank you. Okay, good morning and good afternoon, everybody. It's really an honor to be with you today. As mentioned, my name is Pam Jaeger. I'm a professor in the School for Environment and Sustainability here at the University of Michigan. My training is really in applied economics and policy analysis with application to issues surrounding poverty and environment. In recent years, I've done quite a bit of work on environmental health issues mainly in East and Southern Africa. So I'm coming to you from that perspective. As Girma has already laid out for us, we have an interesting opportunity to make some very quick and important progress in the areas of environmental health burden and climate change. I think we're probably all aware that the pace of climate change is having a tremendous impact in the Sub-Saharan Africa region. And we really are sort of lacking a clear understanding of what the implications of climate change are for a wide range of outcomes, both related to poverty and related to health. So I think what lays before us is really a very exciting challenge to think about how we can integrate environmental data with public health data in order to really inform policy and practice in the specific area that we're all interested in. I'd like to flag a sort of specific issue that I think presents additional challenge and is really a call to action for all of us, which is that really, this is true in the United States, in Canada, in many countries in Africa. The people that work in the area of public health and the people that work in the area of environment and climate change adaptation and mitigation are really quite siloed and don't frequently interact with each other. And I think that this happens in a, sort of across the board in terms of thinking about the stakeholder groups that we work with, governments, non-governmental organizations, academics, et cetera. So I think, the pressure for a call to action, there's urgent need for us to make quick progress in this area. And I view a critical element of that progress being getting these two really fundamental groups of people to start talking to each other. And again, that needs to happen sort of in all domains of stakeholder groups. I think what I'd like to flag for people today is that there are some specific thematic areas that have very high salience for the context that we've been talking about through the course of this webinar. And what I want to say initially is that the sort of demographic surveillance infrastructure that exists many places in Africa, that we have been hearing about all of the sort of innovative and exciting ways that people are leveraging and using these data. These systems have done a good job of tackling two of the key environmental health issues that are sort of part of this suite of things that are becoming increasingly important in terms of health burden on the continent. Water and sanitation and nutrition, with of course focus on diarrheal disease, a host of other health issues, and then nutrition with really good attention to growth and development and micronutrient deficiencies, et cetera. Where we're lagging and where we need really sort of urgent action from where I sit is thinking about issues related to climate and health. We're really just starting to get a very early understanding of the scope of these issues and how we can start to address them from a data science perspective. Air pollution burdens, both ambient and household air pollution burdens, are getting increasing attention and also increasing in terms of their contribution to morbidity and mortality across the continent, with expectation that they'll continue to be sort of moving up the rankings in terms of health risk. So that's another area where we have really tremendous opportunity to put into place data systems that would be integrated with more traditional demographic surveillance type of efforts. And then finally, and we hear a lot about this in the news, but we don't have a lot of good data, in part because it's really hard to track people as they move. We have a massive trend towards urbanization. And if you look at the predictions for demographic change on the continent, 80 years from now, something like 12 of the top 20 megacities will be in Africa. So this is really, just sweeping demographic transition that's taking place. So of course, demographic surveillance systems have a start, and some of them do a very good job of tracking people as they move to new locations. But this is really a very big challenge for data collection and data documentation, and a very interesting area for us to be thinking about tying these types of demographic shifts to health outcomes. So I'll just make a quick note that we at the University of Michigan have started a small collaboration with the demographic surveillance group that's working out of the Aga Khan University in Kenya, where we've had sort of a quick opportunity to get a few questions related to these 5 key areas of population health and environment into the next round of their big 90,000 household or 90,000 individual data collection effort. So that's really exciting, and we view that as a really neat first step towards moving towards this type of ability to answer questions related to these key areas. I'll just flag a couple of things that we, should be thinking about. One is, can we really identify places where climate and environmental health burden is fairly significant or very likely to change, to be dynamic in context over the next several decades? So, really, we have from the environmental data that we can bring to bear on this question some ability to say where the risk is highest, and that gives us an opportunity to focus on and explore in those areas. We can develop questions that are focused on the 5 areas that I laid out for you. And I just want to point out a couple of the sort of data science challenges that come with starting to integrate environmental and health data. The primary among them being the sort of mismatch between the temporal and spatial scales that we have data available to us at. So, there's really a lot of interesting opportunity and innovation required in terms of thinking about how we can be really creative and bold in the way that we bring data together from different sources. So just to give you some specific examples of how we can think about pushing greater integration of environment data with existing health surveillance efforts. Of course, as already been mentioned, we have a lot of information on rainfall and temperature. Some of that is collected from satellites, some of that is collected from weather stations. It's very sort of frequent interval data typically, and provides a lot of important information if we can tie it to the locations of households or communities. We also have very good documentation, particularly in recent years, of extreme weather events. And so again, for regular health surveillance efforts, it's very easy to imagine a situation where we can start to bring these types of data together. Areas where we can really expand and think creatively are putting into place systems for ambient and household air pollution monitoring, thinking about sort of regular collection of water quality, doing some sort of objective sampling of quality, and then soils as well are another area where we have sort of untapped potential and the ability to think really creatively about building more robust infrastructure than already exists to look at these types of issues. I'll flag biomarkers as another exciting area for, again, really rigorously and trying to clearly bring together the implications of environmental health burden with health outcomes. And again, some demographic surveillance systems have longstanding biomarker data collection protocols and really interesting opportunities to leverage that. And then just another thing that we need to be thinking about is what I would call related to the sort of micro environment, the information about household and neighborhood environmental conditions and pollution sources that are sometimes really confounding factors when we're trying to explain the determinants of health in the areas where we work. And I'll just flag importantly that a sort of key to putting all of these types of data together is georeferencing, because that really is the one piece of information that allows us to link across all of these various data domains. And I'm glad that Akbar brought up a lot of the issues surrounding confidentiality and the ethics of data science. And the georeferencing gives us a tool that makes it possible to think about bringing together this individualized data with data that is collected at other, perhaps higher scales. So I'll just wrap up with saying that I think the opportunities are exciting and limitless. And, we're sitting at a point in time where we have really a critical opportunity to leverage the existing infrastructure that's there and to work with partners and build in a very productive and hopefully very sustainable way. I want to flag that in the context of climate change, the issue is urgent and we don't have a lot of time to figure out in terms of climate adaptation, in terms of the health burden of climate change. We don't have a lot of time to figure out what works and how to bring things to scale. So this again really points to building on the infrastructure that has been so ably established in a variety of places throughout sub-Saharan Africa and coming up with really creative ways to experiment, to evaluate, and then to think with an implementation science lens about bringing it to scale. And of course, data science is fundamental to pushing us faster and very effectively in this direction. Thank you.
Thank you to all of our speakers. And before we turn to questions from members of our audience, I want to give each of our panelists a chance to share any reflections or responses they have to any of the other speakers. Pam, you commented on some of the ethics and privacy issues that Akbar raised in his presentation. Would any of our speakers wish to comment on themes that were raised by other members of the panel?
Yeah, I'm happy to chime in here. Clearly privacy is an issue that's not only exclusive to the science for better health in Africa. It's something that we're having to deal with even in sort of other countries too. I think the importance of how we actually share data as we get to even levels of data of genomic information is especially pertinent, because the question is who's getting the data and how are they using it. The first step is to say, okay, well, what can we do? And so there are statistical methods where we can develop synthetic data sets, or what I described a federated learning approach. This is something that we're exploring here at the University of Michigan too. Dr. Singh and the Department of Learning Health Sciences is working on that, where you actually can develop prediction models within your local community or your local university. And then those algorithms, not the actual data, but those algorithms itself can then be shared with each other in a more centralized way. And then that most central algorithm can then be used to sort of facilitate and generalize to the rest of the data sets. That's just one approach. There's other folks at the University of Notre Dame, Dr. Jeffrey Sewell, who's working on a blockchain approach of privacy of data, a little bit more sophisticated than I can talk about. But the reality is, yeah, there are new approaches that we could use, not only from a data science perspective that needs to be enhanced, but then there's also governmental regulations. Those tend to be presumably the most challenging, and I'd love to hear from Dr. about that. Each country has its own regulations around how much of the data can be on the cloud, or which presumably would be the easiest way to share data. But those are sort of the context that I have regarding the privacy and security of data.
Can I comment?
Please.
Yeah, a question targeting the information revolution. Yes, that is true. Currently, it is really a problem in the health facility level. The information is not as organized as we wish. However, the data information revolution has started very few years back, 2018. And along this, there are several activities being done. For example, we have a project known as Capacity Building and Mentorship Project supported by the ministry. We also have very similar improving information system in Ethiopia, which is funded by Doris and managed by JSI, all targeting to improve health information system in Ethiopian health facility providers. Therefore, there are a lot of activities going on, actually, not just by us, by different actors. So although we don't really have a very good system currently, but if you compare it with where we were 2 or 3 years back, frankly speaking, there is a huge change because I'm involving in that project. And I can see from year to year, the only problem was disruption due to COVID last year. Otherwise, we are progressing very, very well. And I'm sure in the next few years, we will really have an opportunity to improve this. Another question was on how data science can be practical in Ethiopia when most population live in rural areas. Well, I don't think it has much connection because we are dealing with data. We are dealing with health facilities, and even if majority of population live in rural areas, they use health facilities. By the way, these days, health facilities in Ethiopia are improving very much. We have tiers from tertiary hospital down to health post. Therefore, people at least go to health post and then to health center and regional hospital to tertiary hospital, then specialized hospital. So in the rural areas, we have health post, health centers. So people visiting them. So there are data coming from this as well. So I think, yes, we are progressing. I'm not saying that there is no problem, everything going well, but there's hope. Yeah, thank you.
Masi, would you like to raise one of the questions from our audience?
I would like to do that, but before I do, I wanted to address a question or something that Ngima has been trying to elaborate upon, which is the fact that there is a bit of concern that given that majority, and it's not just Ethiopia, but several countries have a large population of illiterate population of segments of their population that are still illiterate and may not have access to internet or electricity. And those are challenges, but when we think about data and the types of data that we need to be able to improve health and well-being, we have health data, but there's also this increasing access to mobile phones, which are practically everywhere in most African countries. And how can we really harness those tools as really another layer of data that we can use to improve and provide gaps in our information systems, especially for people who do not necessarily interface with formal healthcare systems. Young people that are healthy may not exactly come to healthcare systems. And we've had a lot of examples of those, including here at the University of Michigan, where faculty have employed user-generated data via cell phones, or really web scraping and collecting a lot of social media data to be able to inform and create these very large data sets that can advance our understanding. And those are really, they are able to overcome so many of the challenges we think about for big data, for example, literacy. Even the most illiterate person can be able to use a cell phone, and you can still train them. So I think we should really give due process to the people in these populations, that just because we classify them as illiterate, it doesn't mean they are incapacitated in being able to contribute to this data that we seek. One of our audience question that I would like to pose to the panelists is really to comment about the challenges of digitizing data. especially that for most of our healthcare systems in Sub-Saharan Africa, we are really still dependent on paper-based records. And what sort of opportunities or what should we be thinking about in terms of being able to harness those data to be able, again, to contribute to the discussion on contributing to health?
Amina, you mentioned in your presentation the transition to electronic health record data at Aga Khan University. How does that compare to other health systems in the region in making this transition from paper-based records to electronic health records? And what opportunities are there, as well as some of the challenges or barriers to digitizing the data for data science and health studies?
So, I think this is becoming quite a common trend. For instance, the Ministry of Health in Kenya has actually developed an integrated health system, kind of real-time data. So all healthcare centers in Kenya input all the data they get on a daily basis. You know, patient data, children seen at maternal, child, and healthcare. So with permission, you can actually access how many people are seen today, what their conditions are. The data is not really perfect. You know, sometimes when you compare what happened and what has been put there, they're still missing data. But actually we've used it and it's really great, you know, a great resource to know that every health center in Kenya has started implementing this. So I think this is a transition that is really picking up and people are seeing the value of having this data to be able to make decisions very quickly. Today I was actually in a meeting where people are being trained on how to better enter this data here in Mombasa and be able to use and interpret it. But just to respond something about you know, low literacy populations. I also know colleagues who are really looking at ways to adapt technology so that even people with very low literacy can collect data. For instance, a very innovative project being carried out in Kenya is to have, get mothers have, some questions with accompanying photos about the child's health conditions and even being able to take mid-upper arm circumference. And if it shows red, they know that's malnutrition, so they don't need to read. They just need to be able to look at the photos and be trained to translate that and regularly keep the data. Now, this is being piloted in a pastoralist community, one of the poorest communities in Kenya. I don't know how that data will look, but already they have the, the confidence that the mothers are actually updating data regularly. And their point is, if we can really train mothers who are low literacy to use, you know, documents with minimal words, but a lot of pictures, we can actually get them to do the monitoring of their own child's health. So I think it also needs innovation and creativity on how we leverage on technology and not necessarily words to be able to reach some of these populations. Thank you.
So maybe I can just quickly add a couple of things. One is that I think COVID is pushing us really very hard to think in new and different ways of data collection and data documentation. You know, there are places where there are lockdowns happening and people are not able to move between districts. And so there's increase, but at the same time, we need information about people getting sick and what's going on in very localized settings. So as horrible as this global pandemic is, I think it's really shaking up the way we think about doing things. I have a very sort of specific example in the world that I work in, looking at energy access. Health centers have sort of notoriously, health centers in rural Africa have been notoriously places where there hasn't been access to electricity. And so that's had implications for all sorts of, you know, what healthcare services can be provided, vaccination programs, et cetera. And because of this anticipated need for a very quick and rapid vaccine rollout, unknown what the requirements will be, the electrification of health centers with solar systems or getting them onto the grid is getting unprecedented attention. So again, as we get, sort of modern electricity sources into these health centers, that presents additional opportunities for computer systems to be put into place, for lack of access to energy not to be an excuse or a reason that information is not getting digitized. So again, opportunity in the face of crisis in a way.
So another question we have from our audience that I'd like to direct first to Girma and then all of our panelists is, what is the role of exchange learning, having students and faculty from our university, the University of Michigan and others in North America, in exchange and learning with students and faculty in African universities? And Girma, as you think about the training program that you're co-developing with colleagues here at the University of Michigan, how does that learning partnership take shape and opportunities? And I think the example that Pam gave about COVID and how we may learn from how Africa appears to be handling COVID better than the United States and in its approach, and other examples that you might have, and I'd also be interested in the other panelists' views on those opportunities for exchange and learning.
Yes, I think our university collaborates with several other universities in the US and then in Europe. So basically, like one of collaborations with Johns Hopkins University, where we have staff from Addis Ababa University visiting Johns Hopkins, and particularly in summer school. And the same in universities in Germany. And also staff coming from these universities coming to Addis Ababa University and offering courses, supporting staff and even students in different ways. And even during this COVID period, we have been providing, for example, training jointly online. And you see, even if you don't travel, there are still opportunities that you can use. Just a few 2 weeks, maybe 2-3 months back, there was a good training program from Johns Hopkins University. They have there is a project, PMA, performance monitoring. So through that, there was a training program scheduled last year, but we did not cancel it. We used online and a video recording. And that same program is going to be repeated in 2 weeks' time. So I think since we already have collaborations and very similar collaborations with the University of Michigan, of course, which I was not involved. Therefore, I am very hopeful that this collaboration is going to be great. One thing, University of Michigan have extensive experience in collaborating with African universities. Therefore, I think we will have a great time, and I hope that we are going to benefit a lot from this collaboration.
Thank you. And I see that we're just at the end of our time for this very stimulating discussion. Any concluding thoughts from any of other panelists or Masi, as co-facilitator of today's discussion?
Can I just make a really quick comment? I know there's always worry in this kind of collaborations that when we bring people from the global north and those from the global south, there is a danger of inequitable benefits from this kind of large studies. I think the core thing as we develop partnership is really open communication and respect for each other, and really agreements on the kinds of things we would like to achieve long term, to ensure equitable benefits. And for instance, if you think of the project we set up with the University of Michigan, or we are hoping to set up when we get funded. You know, we put in really strategic capacity building in Africa to ensure that whatever benefits from these larger data sets from Africa's come out, they really benefit the scholars in Africa. We leave a pool of people who are well trained. So although it was not a training program, we ensured that there was a way for equitable distribution. So that's just one of the one discussion that always comes up when we talk about big data. And I think it's an important thing to always raise. Thank you.
Thank you. Well, I think that's a very positive and constructive note for us to conclude our discussion, the importance about respectful partnership and sustainability. I'd like to thank each of our speakers. Masi, if you have any closing remarks, I would turn to you.
I think we've had a very good discussion here. And again, I think the emphasis here is for us to begin to think about how can we address these issues, drawing on the resources, the partnerships, and the enormous opportunity that exists in using big data to advance health and well-being in sub-Saharan Africa. So I don't have anything beyond what has been shared, but I'm just grateful for the opportunity to participate with you in this panel.
Thank you to our speakers and to all of our attendees in today's session.
Yeah, thank you very much.
Bye.
Thank you.